Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols.
Like POCUS, lung POCUS, because you hear a lot of people talking about that, and then end-tidal CO, like not the non-invasive end-tidal CO2 thing. Not that that's a new topic, but I mean, I personally see people relying on it pretty heavily.
It's an interesting topic. But I thought since there was like the three levels of where a patient would sort of journey from N2, like pre-hospital, ED, ICU, like everyone's, I mean, for me at least, it's kind of like selfish in a way, because I always wonder kind of like what happens in the field, because I do wind up reading the paramedic note, honestly, sometimes like to get more of like a flavor of like what's happened, or like what exactly like what was there, or like just kind of like the milieu of what was happening. And sometimes like they're really helpful. There's like some stuff that maybe like seemed not important at the time, but it actually wound up being important. So I just thought like we could sort of like spitball a patient,
I think
B50s.
Sure.
Yeah,
I think
ahead.
just to pause you, it is really important for the paramedics listening to hear that people actually read the reports, because my dad's a retired neurologist, and he used to say that all the time, that he would read the paramedic reports to find out exactly what was happening at the scene. So it's not just some pain in the ass that you have to do after the call, like plugging in on an iPad. Like, you want to put descriptive information in there so that everybody going on knows what was happening. And I will tell you, from having done expert witness cases before, there is nothing worse than opening a paramedic report and seeing just two lines like difficulty breathing, history of COPD. It's like, thanks.
I mean, yeah, well, I know, right? I think sometimes like with the pre-populated notes, it's easy to just make like a generic note in some ways. I try to sort of free form it on Dragon or something, and just kind of like give more of a narrative and not so much like a bullet pointed thing. I tend to do the plan in a bullet pointed thing. That way you can just sort of like follow along and just like XYZ. But the story I try to make into like a story. So my usual go-to is, if I get a call from the ER or from the floor or something, kind of like review the notes. Because I feel like it's, you get kind of like each person's view of what they think is happening. And then I kind of like put that into my kind of mental model. I don't know if that makes any sense, or if I'm just sort of like, talking out loud, but.
All right. Well, can I give you you guys a hypothetical bread and butter medic case that we go to constantly? Because a lot of these respiratory cases are clear as mud. And one of the things that I think paramedic education does not do well is that since paramedic school's taught in a modular format, just to get as much information as possible in a short amount of time, it goes like respiratory, medical, cardiology. And then within those things, like respiratory, for example, it'll be, okay, today we are doing COPD. Tomorrow we are doing pneumonia. Then we're doing asthma, or in whatever order. So you get people that think that they have to zero in on one disease process. And we all know that that's not the case. And then you get these patients who are just clear as mud. So we will take Mr. Jones, who is 300 pounds. He's 60 years old. He's got a history of CHF. He's got COPD, asthma. He smokes 3 packs a day. He's got a belly that, sticks out like 1.5 feet past the end of his pelvis. And he's got severe shortness of breath. You put the bell of the stethoscope on his chest and you hear a diminished combination of like wheezing, rails, bronchi, the whole 9 yards. So you listen to this guy's chest and you think like, well, I know it's sick, but that didn't really tell me any useful information. He's hypoxic in the 70s, tachycardic, hypertensive. So can you go down like just where would you start from there, you guys?
That's a good question. I think if I'll just give one point, Scott, is I try to think like, I've really tried to think in terms of, and there was actually this paper that I stumbled upon that I have read before, but I forget the name of it. It's something to the extent of something about like the sort of maximal mandatory minute ventilation, and I'll send it to you, Crunch, because it's actually a really good paper. And essentially, it comes down to like people sort of get you know hurt by the worker breathing, sort of like this tiring out phenomenon. Based on a few different mechanisms, and then really comes just down to like a compliance or a resistance issue. So if I see a big guy who's got he's got all the fixins. He's got the asthmas, the COPDs, he's obese, he's hypertensive, he has heart failure, maybe he's got some fluid on him. He probably has OSA to some degree, smokes. Like I really try to tease out from that point, is it more of like a compliance issue? So is it like pneumonia, pulmonary edema, just his like chest wall? Or is it a resistance thing? Like he's in COPD exas, he has an asthma exas, he has some other bronchospastic sort of situation happening. And then, there's like sort of other things like diaphragmatic weakness. So if you have like neuromuscular disease, or if you've been doing a bunch of drugs or something, you're sort of not going to breathe. So I really try to approach it from that point, and not from like what I think the diagnosis is, or because as you point out, like wheezing, bronchi, rails. I mean, I don't know. I it's like few and far between. Do I hear rails and I'm like, oh, this was like sort of like the linchpin, like this really helped me figure it out from, a physical exam perspective.
Yeah, I like where that's going. I'd go even further down that road for EMS and emergency medicine, because, and this is kind of unique to those specialties, is a kind of a lack of caring of what it is. Even more than you're just dichotomizing to compliance and resistance issue, because the way to play, if you want to win, is to symptomatically treat until enough evidence accrues to actually start pinning your, diagnosis down. But you don't really need to. This patient, the primary thing that worries me, obviously, is the hypoxemia. And when you see that, your first inclination is to put the patient on oxygen. And anything above 40% FiO2 eliminates, a wide swath of the causes of hypoxemia. So, VQ mismatching is gone. It's not an issue anymore at 100% or as close as you get FiO2. So we don't care about it. All of that other stuff, alveolar diffusion issue, they're all gone. And what you're left with, essentially physiologic shunt and maybe some contribution from poor venous oxygen saturation. And let's not even get bogged down in that latter one. So you're left with physiologic shunt. So we know the solution to that. We have to increase the patient's mean airway pressure, which is just a fancy way of saying put them on some form of non-invasive that has EPAP on it. You're going to increase your mean airway pressure, and they should get better regardless of what it is. So you're like, oh, well, it could be the COPD and asthma. Well, no, it can't be. If they're moving gas, if they have enough of a tidal volume to get past their dead space, then it's not it. Because at 100% FiO2, even the tiniest amount of oxygen entering their alveoli is enough to fully saturate them. So you don't have to care. You just basically have to make the determination as you listen to their chest, is there air movement or not? And if there is, then they're going to get fixed in terms of their hypoxemia by putting them on non-invasive and dialing up the PEEP or EPAP. So that's where I'd be on this patient. And then we'll let things kind of reveal themselves as the stabilization continues.
Yeah, no, I think most medics by now, hopefully, would throw that guy on non-invasive ventilation with maximal oxygen right off the bat, whether that's CPAP or BiPAP's becoming more, it's emerging in pre-hospital care. It's no longer just something that's done on critical care transports, especially now that a lot of services are getting vents. So, yeah, would you have a preference in either or, Dr. Weingart?
Yeah, and I'm curious to hear what Nick has to say, because he's on the pulmonary world far more than me. But this was this big question in emergency medicine a decade ago, and people would fight, oh, use CPAP, oh, use BiPAP. And it was a complete misunderstanding that anyone who's done critical care training understands, is that's not the way to think about it. The way to think about it is it's just a machine that has dials that do different things, and your expiratory pressure, your PEEP, your EPAP, is to increase your oxygenation, and your pressure support or IPAP dial is to increase the amount of their minute ventilation. And so if they need the help with their hypoxemic state, then you need the EPAP. And I don't care if you have that by a CPAP setting or a BiPAP setting or a CPAP mask or what have you. That's all they need. And if you put BiPAP or inspiratory pressure on top of that, nothing is helping on the hypoxemic side. That's not it. Now, on the other hand, if you have type 2 respiratory failure, if it's a CO2 issue, then the EPAP's not going to really help you. It might even hurt you. And we could get into arguments about, stenting open COPD lungs, but it's an academic exercise. What matters is you want to increase their minute ventilation, blow off more CO2. So you increase the inspiratory pressure. Now, obviously, if that is your issue and you just have a CPAP mask, it's not going to help that too much. It's not going to do nothing. So if that's all you had, I'd still do it, because you can have effects just by the augmentation of the continuous respiratory cycle. But the idea is start thinking about those dials separate purposes. The inspiratory dial increases your amount of tidal volume, your minute ventilation. The expiratory dial increases your mean airway pressure and affects your hypoxemia. And then all of a sudden, it's not a question of CPAP or BiPAP. It's a question of, what do I need for this individual patient's respiratory failure?
That's I think about it this like a similar way. So a lot of times I'll maybe get called, we get called or for a patient that, let's say, I have pulmonary edema or something and they're sort of hypoxic, and because of like this work of breathing situation, we'll wind up on BiPAP like 10/5, 12/5. And sometimes I'll just sort of like walk the IPAP down, but increase the PEEP, and then sort of get to like some CPAP of 10 or 12, and everything seems to get better. And so I think in the same way it's Scott, though, like when you have like a work or breathing issue, when you're breathing closer to like your residual volume, you're going to be working harder, right? So if you can sort of like recruit that lung, like sort of closer to your FRC, it's going to like ameliorate that feeling that like you have to work hard. Whereas in like asthma or COPD, you're sort of like trying to offset the work of breathing from the diaphragm because it's so fatigued from working so long with IPAP. So in patients with like a compliance issue with like pulmonary edema, or I guess even like pneumonia to some degree, but that gets a little bit more sketchy. But we'll just leave it sort of like bread and butter, COPD, asthma versus like pulmonary edema, I guess, of any flavor. Sometimes I'll sort of like take them all BiPAP and just do like a CPAP, but a higher CPAP, like 10 or 12. And then you give them some time, they recruit up, and then they feel a lot better, and you can sort of like back off on the pressure. But I feel like when we call upon a patient like working to breathe, our natural inclination is to like, we need 12/5, we need 10/5 or something, when you really need to think about, I think, the sort of like physiologic and sort of pathophysiologic basis behind it would be my
I couldn't agree more.
thought.
That is such a good point, and I really want to emphasize it, maybe in some language that would be super obtainable, because if they took nothing else from this podcast than what Nick just said, it would be a win, because it's so important. So two things that were in there that I want to emphasize. One is we think that, the standard setting for everyone, 10/5, and it usually is a grossly inadequate PEEP. And so since you have to move those in tandem, if you were going to keep that same inspiratory pressure, then you really need something like he said, like 17/12, or you could just make your life easier and just go with the 12, because the 17 is not doing anything for that patient. So that's the first thing. The second thing is, I don't know if you guys have ever had a kid's birthday party. I'm sure you usually have. And you have those tiny little balloons that they sell like 100 to a packet. And when you first try to blow up those little bastards, like you have to put, like, your entire face goes red. It's so friggin' miserable. And then once you get a little bit of air in, it becomes a real joy to continue to put more breaths in there. It's not hard anymore. Well, what happens when you get a patient with a high work of breathing from something like a pulmonary edema or a pneumonia is all of their alveoli have lost their surfactant. They've collapsed down around the areas that are involved, obviously. And so they're all those tiny little balloons. And so each breath the patient has to take, they have to re-blow up like thousands and thousands of those tiny little balloons, and it's miserable. And if you just help them out by putting a little bit of gas in each of those alveoli, which their surfactant would naturally have done before it got destroyed by the fluid or the pneumonia products, all of a sudden they could take breaths quite easily. So you fix their work of breathing, but it wasn't an inspiratory pressure issue. It was a keeping the alveoli open enough that their work of breathing is simple with each breath to open the alveoli, versus the miserable, like, face red blowing up the balloon each and every breath.
Yeah. And I think like it's not, I don't know, Crumps, like and you would know, like obviously know better than I would, but I know it's like a hard call. Like, for me, putting someone on like a CPAP of 10 or 12 or 14 or something is not, that's like sort of like what I do. I'm sure if someone, like medics, you grow up on people, you don't really know what's happening. They're like at home, they're like, maybe they just ate, like there might be a little bit of sort of like, apprehension to do that. I don't sort of just crank it up, right? I sort of like walk it up by 2 and just like sort of see how the patient does. And then it's, I can get to, I don't know. I've gone to like 16 and they've been better and
Right.
I just sort of let it there. And then once they start to sort of like get better, I do back off. And I do, the one thing that I really watch, like is the pressure. I watch the pressure, but the one thing I really watch is the volume. So, if I come down, if I see a patient on the floor in the ER or something, and they're on, 12/5 or I don't know, 16/8 or some sort of smattering, and they're only getting a total volume of like 300 and they're breathing 30, this like really makes me nervous because I don't really have much more, like, unless I really figure this out soon, I'm going down a much different path. So I really pay attention to the volume. Similarly, if they're on a, like a 12/5 or 12/8 or whatever it is, and the total volume like they generate is, 500, 550, and they don't look terrible, even though they're on maybe a little bit higher pressure, like I know they're getting a volume. So if they're still short of breath with that, then, like a compliance issue is sort of out of my mind. Like, is it something else, I guess? So like the volume is something I really pay attention to, like with the delta pressures that we put patients on.
And you could, pre-hospital people, you can monitor those on a ventilator, but on the, I don't know if you've even seen them, Nick, the
Yeah.
plug in oxygen and go CPAPs, the flow vents,
No.
they're just, you take it out of a package like a non-breather, put it on the face. I've actually advocated for those over vents for applying PEEP pre-hospitally, just because I think it dumps off the cognitive offload. You get so cognitively taxed with some of these patients, and it's just you and your partner. Sometimes your partner's an EMT. Sometimes in some places it's a volunteer firefighter who has no clue.
Yeah.
And you've got a million things to do. And, I see some of these EMS administrators who are like, oh, we're bringing the ICU to the patient's house with these ventilators, and they are phenomenal. But I'm like, in the house, just throw this guy on one of these plastic CPAPs.
What kind, like when you say the ventilator, like, is it like a Zoll or is it, you mean like the T1? Is that what you're talking about?
I mean, I don't get paid by anybody here, but it's much easier to see those numbers on the Hamilton.
Okay. Yeah. No, it is. I mean, I've seen the Hamilton a bit, but not a ton. So, yeah.
The other thing is on these big boys, when they get sick, just to get them to like their 0 level takes a bunch of
Yeah.
PEEP. And so I definitely start higher than you're used to. There's very few patients I would start 5, if they're satting 70%. 10 is a nice starting place. And as Nick said, you can just walk them back if you need to. But, especially on the big boys and girls, you need more PEEP than you think. Like 12 might be 0 for their alveoli to actually see.
Gotcha.
And then it's above that they start actually getting increased mean airway pressure.
Yeah. We see that a lot. Like, it's just to make a point, if we drop like esophageal balloons in, to measure like pleural pressures, a lot of times when the patients are on like 12 of PEEP, you'll get an expiratory pleural pressure of like -1 or 2, meaning you're not even at 0 and you're at 12 already. So, I think we sort of like underestimate how much PEEP the obese patients like really need to really start to generate sort of like a positive mean airway pressure. So, so like on a good day for Mr. Jones, his CPAP of 10 that he used, or, he probably doesn't use every night because it's too much pressure, that's like probably just enough. But if he sort of like takes another hit, whether it's from pneumonia or pulmonary edema or whatever it is, like you're really going to need to give him more pressure. And it's, it is nerve wracking, I think, when you don't sort of use it every day and all of a sudden, like you're maybe in his house and you can't breathe and he's sat in 70%, he's like 500 pounds. Like, how are we going to get this guy on the gurney? And then you slap like 12 or 14 centimeters of water on his face. And it's like, you're like, we're like, that's really, in like dicey territory. So I don't take it for granted, like, what medics and people do, like sort of, especially in like people's homes or on the street or like on the street corner or at a party or whatever it is, because it can, like this stuff makes us nervous in the hospital. So I can only imagine what it does when you're sort of not in the comfort of a hospital.
So we got Mr. Jones on PEEP. Do you guys hear a staticky?
I hear a
noise?
staticky noise.
You do?
I do. Now it's gone.
There you go. It's gone. Okay, cool. All right, so we've got him on PEEP. His oxygen has started to climb a little bit, but you work where I do in Pennsylvania and all the hospitals closed. So now you have a 45-minute transport to the closest hospital. So he's starting to get better. And it's not like when I worked in the urban area and we could just be like, all right, let's haul ass 5 blocks of the hospital and make him Dr. Weingart's problem. We have to make some decisions as far as treating this gentleman. So we have pulmonary edema protocols, we have bronchoconstriction protocols, and we have assessment tools. Our lung sounds didn't tell us a whole lot. History doesn't really tell us a whole lot because it could be anything going on with this guy. So what are some tools? I wanted to talk a little bit about lung POCUS because we don't do that. We may be getting it. I'd be interested to see what you guys have to say about that. And then we have always been taught as medics that end-tidal CO2 is the end-all be-all. And I think it's a good tool, but I do sometimes see some limited utility with it, and it can be a little bit misleading.
I mean, I think Scott and I probably have a similar, like, I think doing the hokey pokey in these situations is like really helpful. And like sort of the blue protocol from Liechtenstein, which I think was probably like the early 2000s, sort of like a starting point, meaning like, shortness of breath with, B lines or sort of like signs of congestion versus shortness of breath without B lines or, A lines, plus minus lung slotting. That really helps you, take a lot of things sort of out of the equation of what it could possibly be. I have to be honest though, in this situation, like sometimes it's not as helpful because Mr. Jones is probably going to have a bunch of B lines and, he might have some areas of A lines. Like, is it going to help you a ton? But for some reason, whenever I like do POCUS or if I'm like not exactly sure, putting the probe on the patient oftentimes like helps me. It doesn't like I often walk away like knowing a little bit more and like sort of being able to sort of assimilate the other data better with having like a dynamic test that I performed kind of like in my mind would be sort of.
What do you think, Doc Weingart?
Yeah, I'm torn because there's in prior discussions I've had of ultrasound, and I am a huge advocate of ultrasound. I've had advanced training in ultrasound. I think it's indispensable for what we do. But there's a tendency for people to use it as a masturbatory tool, in which they bring themselves pleasure, but they don't really do much. Something's playing in the background.
Is it? I just took my. Can you hear anything?
Yeah, we're getting
now.
it now.
Oh, okay, I took my earbuds off because I had a little bit of static. Let me go on. My apologies.
Yeah, so you could get fascinated by the potential of ultrasound to help, and you could spend time that should have been spent stabilizing the patient. It's super helpful when you well, first off, if you already have a diagnosis in your head and then you want to disconfirm, right? So you're like, oh, this is clearly a crashing pulmonary edema patient, and the patient's blood pressure's high, and you're like, okay, well, let me just throw on the ultrasound, and you see those B lines, fantastic. You keep going with what you're doing, but your entire plan will change if they have clear lungs on that ultrasound. Something has been misread. So that it's incredibly helpful there, and if you find unilateral findings, also, game changing, because your entire plans are going to change if, it turns out the patient just has what looks like interstitial edema on one side and not the other. Again, you have to reevaluate your whole diagnosis. Now, in the field, and, this is really relevant to the discussion that Nick and I had with the crashing pulmonary edema patients, there's a phenotype for a patient who classically presents this way, and if they fit that perfect phenotype, do you need ultrasound? No, there's not too much to give you a blood pressure of 210 and severe respiratory distress and sweating, and there's not too much else there. But your Mr. Jones patient, in this case, it would be really helpful to know, because if you showed me completely clear lungs, it would be very weird for them to have that sat of 70%. If they got put on some oxygen, it would be okay. If they had that sat of 70, you put them on a high FiO2 and all of a sudden their sat's okay. They still look, in distress, but their sat's fixed. Okay, fine. It's COPD or asthma or something like that. No problem. But so it might be nice, but there's a trade-off. I mean, it's an enormous training load. It's an enormous, again, like it's a cognitive distractor. So I don't know. You start telling me 45 minutes, Mike, I kind of like medics having access to ultrasound. You show me that urban environment where they have 15-minute transports. I'm like, no, we could put our resources into better things like maybe pre-hospital blood or things along those lines. So yeah, I'm torn with it as a broad-based EMS discussion, but you tell me a specific scenario like you have, and then it'll be a different story.
I entirely agree with you. I think it would be a useful tool with longer transport times, but I definitely see what you say about the masturbatory aspect of it. Like, this is a pulmonary discussion, but people are talking about it. Well, we need to get it for trauma patients. It's like we're taking the patient to a level 1 trauma center anyway. Like whether their fast is positive or not, we're going to be taking them to the appropriate facility. And if there's any indication of an increased shock index or bleeding, we're going to be giving them blood because we carry blood. So I don't really know what the utility so much would be.
I'll push back on that, even though I don't want
Please.
to.
No, please.
It's not going to be in most systems. Most systems, just as you say, it's useless. But there are some systems, and I don't like this. I think it's a bad idea. But there's some systems that will triage directly to the operating room. And so in those systems, if you told them positive fast and hypotension, it will significantly change their care, because then you could bypass the ED entirely. And no matter how much people pretend that, we'll take the patient and we'll get them up to the OR just as fast, as soon as they hit one place, there's an inertia. And it's not even our inertia. We want them the hell out. It's the inertia of the surgeons. Then they start considering, should we get a CT scan or not? Oh, let's stabilize them a little bit down here. And when you look at the actual times on paper, if you did your ultrasound in the field and found that positive fast, it might be a time to operating room of like less than 3 minutes, because you're going right from the door up to the OR, versus 25 minutes in the ED for a patient that just clearly needed their abdomen open and whatever vessel was, they were exsanguinating from clamped off. So it can make a difference in systems where they're willing to do that. If they're not going to triage directly to the OR, then it's not going to help, just as you say, Mike.
Very excellent point. What about end-tidal CO2? The utility of it, because I from my experience as a paramedic, I have put it on these complex respiratory patients, and of course I've seen the shark fin waveform. You can see sky high end titles in these retention patients, but I've also seen it where the value seems to make no sense and the waveform is just some like artifacty blob as you're bouncing down the road. So I think as good as a tool it is, I think it can be misleading sometimes. And also the value, they don't really train in paramedic training that the lung sicker the patient is and the more dead space they have, the less reliable that value is going to be. So what are your thoughts on end-tidal?
Yeah, that's a fantastic point. I love end-tidal, but with the full agreement of everything you just said, end-tidal's purpose is there's no better respiratory rate marker. And it will tell you when the patient gets apneic, and it will tell you when their perfusion state starts going to crap. And for all those reasons, it's invaluable. It is not a good marker of the patient's blood CO2. And that's where people go wrong, is they think it is. What you can say is that their PA or PV CO2 will be at least as high as their end-tidal. So if you see an end-tidal of 80, that's a patient who is severely hypercapnic. They could have 80, they could have 120. If you see an end-tidal of 20, you can't say anything, because for the exact one of the reasons you mentioned, the dead space, but also shunting and poor perfusion to the lungs, all of those cause a discrepancy. And the sicker the patient, just as you said, Mike, the more the discrepancy is going to be. So if you see an end-tidal of 20, then their PaCO2 could be 20. It could be 40, which is normal, or it could be 80 or 120. So you can't make determinations on the patient's CO2 status based on end-tidal if it's low. If it's high, then their PaCO2 is at least that high. So you could make some determinations. You go up on your vent respiratory rate or increase your inspiratory pressure on a BiPAP. Now, the waveform determinations, I feel like it's reading tea leaves sometimes, just as you allude to, Mike. Yeah, like if you see something super classic like that, asthma or COPD pattern, fine. But most of the time, just as you say, it's just blobs, it's movement artifact, it's patients not fully, having the device seated in their nose. Yeah. So I just like it as a number to trend, so in a shock state, you watch the patient's end tidal go from 20 to 15 to 10. That's a patient who's about to die, right? Like that's an invaluable use of end tidal as a perfusion marker in shock, or, the ultimate shock state, cardiac arrest. It's incredible how useful that is, but not to make waveform determinations and not to have exact precision on CO2 estimation. What do you think, Nick?
That's so funny because honestly, I haven't really used it much like in the inpatient setting, sort of like on a day-to-day basis. There's been more of a push, I think, to use it when patients are on the ventilator. Like the servos at the bottom, like they can have the end tidal, like at the bottom. When I see a shark fin and a patient has asthma, I point out to the residents like, hey, that's shark fin, like this is the physiology, et cetera. So from that perspective, it's fine. When I have a patient with COPD and they're intubated and like the respiratory rate's 10, their PCO2 is like 90, the vent's just alarming because the high number is 90. So everyone just gets annoyed. I'm just like, just make it higher. So, in that situation, I don't find it completely helpful for me in those situations. Agree with cardiac arrest, agree with like perfusion states, agree that if you have a patient with DK and they're breathing 40 times a minute and the PCO2 is 19, good. If it was 50, I'd be nervous. I think you really need to, it's like very patient specific outside of certain areas, like monitoring for apnea 1, cardiac arrest 2, sort of like perfusion 3. So in the other areas like sepsis and like respiratory failure, I'm not really sure where to put it. I personally don't use it as much maybe as I should. I do use it if we're doing like some kind of like a moderate sedation procedure, just as like sort of a marker of safety. But I very rarely say like, oh my God, I wish we had that end tidal CO2 on. I would have really cracked the case for me. But I think it's just like what I do and like on a day-to-day basis, more or less.
What do you think about making vent changes based on end tidal CO2? Obviously, if it's a gunshot wound to the head that you've intubated and their end tidal is 80 and you look over and they're being ventilated at a rate of 10, you're like, all right, I'm under ventilating this patient. I got to fix that. But like in the sick patient that we're transporting, like that septic patient or that respiratory failure patient, because I see it on the helicopter more than anywhere else. That end tidal will be like 52 and you see like, oh, we got to crank the rate up and get that end tidal back to normal.
Look, if as soon as your cognitive bandwidth opens to the point of like, we're going to make precise vent changes to care whether their PaCO2 is 52 or 40, knock yourself out, right? Because there is a point in most transports where you're like, all right, like things are settled down and, you do your cycling through patient vent monitor and everything's looking good. Now you can start going to precision. My fear is always that people will start optimizing for perfection when they should be keeping the patient alive, right? The experienced medics, they understand this, right? Once the bandwidth opens, knock yourself out. And yeah, if you see 52 on an end tidal, then they're at least 52. So you could keep dialing up the respiratory rate until they hit 35 on the end tidal, which in most patients will correlate to 38 to 40 on their PaCO2 if there's no VQ mismatching shunt or perfusion issues. And so, yeah, it's fine. But don't I almost wish that the protocols would be built from the true cognitive perspective, which would be like there'd be enormous boxes on like, keep the patient from bottoming out their map to 30, right? That's bad. And then like precisely dialing the respiratory rate would be like a tiny little box that you need a magnifying glass to read so that like only the people who, are willing to pull out that magnifying glass would actually get to that level of obsession, because in some people who aren't experienced, that will knock out the big ticket issues. And we see this, I'm sure, in EMS. We see it far more in emergency medicine, where there's so many more little boxes that distract from those great big ones.
Sure. Okay, so let's say that we now come to a decision point where we're going to treat this guy. And the big worry that I think medics experience is I've treated this guy for a COPD or an asthma exacerbation, and they end up having heart failure. Or I have started giving this person nitro, and they end up not having any degree of heart failure. I kind of feel like in a lot of these respiratory distress patients pre-hospitally, even with 20 plus years of experience, I feel like I'm shooting in the dark sometimes, because we don't have all the good diagnostics. So what's the risk of erroneously maybe giving that COPD guy nitro, or treating the CHF guy like a COPD exacerbation? Because it's dogma. Nick and I have talked about this. Nick, you did one of your strongly worded rants on this, on the old medic mantra that albuterol will cause the patient to go into flash pulmonary edema. So what are the risks of treating these patients, like making a decision and you weren't right about it?
I mean, we do that all the time, to be honest with you. We always sort of like, my approach, and this is sort of, the longer I do this, and I think like it's easy to always look back and say they had COPD, it was obvious, but our Mr. Jones, who is really more common than we think, if you get an X-ray, I mean, he's going to probably have some degree of pulmonary edema. So is that Lasix really going to hurt if he had COPD? If he gets one dose of steroid and we're like, you know what, this actually might be, is that really going to hurt? It's probably not going to hurt, I think. And when you're not sure and he's satting 70, like you need to sort of do things and then on the back end, figure out like what helped. So I think it's really hard to know, especially in these patients, like what's the primary focus. And I remember sort of like being a student and, one of like after the new lectures was like how you tell CHF from COPD. And we talked about like, rails versus bronchi versus wheezing. And I'm like, I don't know. I kind of hear everything when I listen to like patients that have, both respiratory and cardiac issues. So I tend not to focus on like what's the diagnosis up front. It's just like, how do we get them out of hot water? And then after the fact, we can start to tailor our therapy. So if we give them a dose of Decadron, we give them some albuterol, whatever it is. And then we're like, you know what? I don't think it's actually COPD, like exacerbation at least. You just stop the steroids. I mean, it's not really kind of like that dangerous. There's certainly medications that you give, and if you're wrong, that are dangerous, right? If you think they have an ischemic stroke and you TPA them and like somehow you figure out that they didn't have like an ischemic stroke, like, yeah, that's exposing the patient to real risk. But for, Mr. Jones, you roll up on him, he's sat in 70, he weighs 500 pounds. You hear everything under the sun. You put him on CPAP 10, he gets better. You decide to give him Decadron and Lasix, and in 6 hours, he's much better. And then we can sort of tease these things out. I don't know if I see the downside to that. I mean, and honestly, it's probably not a great answer because I feel like, we always like want that diagnosis. But getting back to what Scott said earlier, I really try to operate off of perfect is the enemy of good. So I just want to sort of be good and get the patient out of hot water and like keep them alive until we can get more data and then sort of like tease things out further.
Yeah, I go along with all that. And, it's a lot of it is cookbook medicine. And like people have this disdain for that, but they're in specialties that generally don't understand that that's the way you play. So if I heard wheezing on this guy, sure, it could turn out to be a cardiac wheeze, but who cares? Just give him the albuterol. And, if the blood pressure's high, you give nitro, but sublingual. Now, where, we had this huge debate from one of your previous episodes was like, should we be doing a SCAPE protocol or, crashing pulmonary edema protocol on these guys? And if they got markedly better with the BiPAP and their blood pressure's through the roof, I'd say no, because it's kind of muddy. And so when we talked about should there be a pre-hospital use of things like a milligram of nitro at a time, yeah, there probably should when it's that classic phenotype. The patient's blood pressure is 200 and he looks like he's going to die and he's sweaty and you listen and there's rales on both sides. I think that's great. The fear I had expressed, when I put out my podcast was, well, are they going to start extrapolating that to a guy like this? And I personally in the ED, you haven't told us his blood pressure, but like, let's say it was like 168, right? So it's above that 160 threshold, but he's better now and he's not sweating. And like, I wouldn't give a milligram of nitro at that point. I'd let things settle down and figure out what the hell we're dealing with versus, that same guy, his blood pressure is 188 and he looks like death and you put him on the BiPAP and he still looks like death. Yeah, I'd give a milligram of nitroglycerin. So, I think when it gets muddy is when you get more information and you stabilize, just as Nick said. So I don't have a problem with cookbook as long as like you're not doing things that require a clear diagnosis, if that makes sense.
Does make sense. You always hear these medics say, "Oh, I don't practice cookbook medicine." And I always tell them, "You have a protocol set. What the hell do you think you're practicing? Like, of course you're practicing
I practice cookbook medicine sometimes.
Yeah.
Like you're short of breath. We're doing so to like make this just a little bit more sort of, not want to say controversial, but like when you get to the ED, let's say,
Great.
and then they have like a little fever, right? It's like 100.9, and then they ring for sepsis, and then do we give antibiotics? And we're not sure, but they're on BiPAP and they're hypoxic. Like for me at least, and I've heard Scott talk about this before, and I have my own feelings about like this criteria and CMS and all that stuff. But like for me, if I'm not sure what's happening and I have like an inkling and they have some like end organ dysfunction, I'll give antibiotics up front, but I'm really, really cognizant about the back end. Like, we can always say we'll give antibiotics and we'll get more information. It usually just winds up being like continuing them for like days and days. But if I don't have a diagnosis, or if I have some other likely diagnosis that's not infection or sepsis, I try to be very really good about stopping the antibiotics. But oftentimes up front, I mean, how do we know the white count's 20, they have a little fever, they're tachypnic, they're on BiPAP, they're short of breath, you get an x-ray, forget it, everything looks like the read is like edema versus pneumonia versus CHF versus atelectasis, just like not helpful at all. And then we're not going to sort of like CAT scan everyone. Even if you did CAT scan them, they all look the same, sort of like, ground glass consolidated infiltrate. So I tend to like treat more broadly up front, and then whittle things as I get more information as we go along. But you have to do that in like a very sort of like measured fashion, because it's very easy to continue everything like day after day after day if you're not really thinking about like what we're treating.
Yeah.
So glad you guys brought the, oh, please go ahead.
Okay. Yeah, I was just going to say, I do this entire series of Mind of the Resuscitationist, which is just on the mindset side of resuscitation. And you always just want to fail in a way that makes you look brilliant, rather fail in a way that makes you get sued, right? And so, to Nick's example, we have this patient, I don't know, they're sick, but is it really from sepsis? They have these very middling markers, slightly elevated white count tiny fever. Okay, I could like be smart and conserve the antibiotic supply and not give it. I'll wait for things to develop. And then, the patient crashes from sepsis on the 8-hour mark on the floor. And okay, what did I really save? I saved 1 dose of antibiotics versus, all right, I'm just going to empirically give the first dose, and I turn out to be wrong. It was viral, or it was, just COPD exacerbation, what have you. No one is going to look at that and say, wow, that fucking idiot gave those antibiotics, right? So you just start asking yourself, like, since I'm not going to have all the information.
They will say the reverse, right? If the reverse will come up, like they had the signs of sepsis, you didn't give the antibiotics,
Yeah,
now
100%.
now they're dead. So
yeah, retrospectively, everything becomes immediately clear when you already know the diagnosis. So
yeah.
I just want to fail well at all times. And you say it harkens back to the cookbook thing. Like, I went to culinary school. I use cookbooks all the time. It's a brilliant way to go when you're learning new things, or you don't really know what's going on, or you don't feel like reinventing culinary extravaganzas there's nothing wrong with cookbook, and it's necessary. Like Nick's job, less so. They have a little bit of time to be really smart. In emergency medicine, and even less, time in EMS, you don't have time to be smart sometimes. So what you do is you fall back on the cookbook, and that opens up the cognitive bandwidth to say, so as I'm doing cookbook medicine, is there something anomalous? Is there something weird going on? Does my spidey sense tingle? And if you are thinking through each and every decision, I don't do cookbook medicine, I decide each one, there's no space for that. And those people actually get screwed more than the cookbook medicine people, because they have wasted their complete cognitive bandwidth on decisions that should have been made what we call heuristically, right? Just through your intuition and prior training. You act heuristically, and then yeah, exactly right. And then you evaluate your decisions with that extra space it frees up.
Yeah. And the only way you can question your heuristics, and if something is wrong, like sort of avoiding bias, is if you have time to sit there and like, okay, we're really thinking about like, did I really, am I missing something? Like there was, the business world does this much better than we do. Like we are sort of like, so like staunchly like I'm right and this is it. But, there's like this sort of I've talked about this before, but like this black swan analysis where you assume you fail. So we assume Mr. Jones dies, right? I mean, like not like telling his wife, like, what if he dies? What do you think happened? But, you're talking to the team and you say, Mr. Jones died. Like, what do we wish we would have done now that we didn't do? And then you'd be surprised what people like come up with, like sort of off the wall stuff. And, it sounds crazy maybe, but you're like, maybe it is that. I don't know. But you need to sort of get to a place where you can have that discussion and think about that. And doing this cookbook stuff, like relying on your protocols, like relying on doing the simple things correctly, gives you the time to do that. But if you're just trying to sort of like micromanage every single decision, or every like, oh, the PCO2 is 52, we got to make it 45. There's no time to do that stuff. And that's where for me at least, the guiding light is, perfect is the enemy of good. And I just want to be good enough most of the time. I would love to be perfect, don't get me wrong, but can't happen all the time. So
I think that's great. I mean, we've gone 45 minutes. Do you guys have anything you'd like to wrap up with? Or I appreciate you guys coming on. I really think like pre-hospital, well, everybody, but I think especially pre-hospital is going to get a lot out of this discussion.
I think, no, I honestly, and the one thing I did want to say is like, I do read the medic notes. Like, I read the notes. I swear to God, I promise you, I read every note. I read the triage nurse note. I read the ED note. I read the resident note. I read everyone's notes, because sometimes there's like things that are in there that if a patient like doesn't repeat, because we've asked them so many times, like, what happened? They've been short of breath. How long? You have chest pain? Is it burning? But you'll find like an Easter egg somewhere in there, and it can really help. Like, if things get more unclear as things sort of like progress, it can help. So I know it's paperwork and it sucks, but like, I read them, and I appreciate like when there's more like discussion, or like describing the scene in some ways, because I feel like it could be helpful.
Yeah, I'll second that. And the thoughts that go on when EMS is deciding what to document, it's a lot of it is protective for understandable reasons, and that makes complete sense, and you got to do that. But once the patient gets to the hospital, that's not what we're going to be looking for, is the extensive paragraphs about the actual treatment administered. But it's invaluable to know what their house looks like, what they were saying. If they might be unconscious by the time we get them, and that you guys might have had the only real contact with these patients. Time of onset of things like stroke and things like that. It's just, there's no one else. Like, you folks are only eyes and ears into what was actually happening at the beginning of their care. So yeah, you don't want to make already difficult job even harder by asking for more documentation, but just 2 or 3 sentences about that initial presentation would be, the game changer. And then, we don't really care if I'm sure your supervisors do, but we don't really care, and then we administered 2 milligrams of lorazepam, and that, that stuff, if it's electronically captured, I don't even know if that needs to be in a narrative. I certainly don't put that stuff in the ED narrative. Like, if I did a CT scan and labs and all that, I don't talk about that in my discussion, because it's already there, and I just see my colleagues just wasting time talking about things that are already in the chart. The story is what matters, just as Nick's saying.
Yeah, agree.
Drives me nuts when I get a QA. It says you administered 5 milligrams. In your treatment summary, it says you administered 5 milligrams of Versed at 14, 15 hours. Like, but you didn't document a reason. It's like, I documented in the narrative that he was seizing. Like, what's the point? So cool.
Yeah. Last point. I also, I don't know. I feel like that's like a lost note, writing technique is like not, do I really need to put like the CT head showed X, Y, like the CT head's there. You just look at the report, just say, and really the stories, like building the story to what happened. Because oftentimes I'll say like, what do we think is happening? And everyone's just like, I don't know. I'm like, what do you mean you don't know? It's been like 2 days, and we like, what's happening? Like, what do we think is happening? And I know that comes with time and like understanding and being able to sort of like build a story, but starting from like the start, which is a lot of times it's like medic, BIBA or BIB EMS, brought in by EMS, like for shortness of breath, found at home, a bunch of pills lying by their side. Like, that stuff's like super important, especially as Scott said, like these patients could be, intubated, unconscious, coding, whatever it is, by the time I see them, certainly. So I can't get any more information out of them. It's hard to sort of like track families down sometimes. So the only like actual interaction, or like what happened, can be from the medic side. So I think it's like super important. So don't feel like people don't read it, because I certainly do.
Well, Doc Weingart. Oh, please. I was going to say you're new to the podcast, so I'll give you the last word.
All right,
Because
great.
Nick's been here.
I was going to say,
Nick's been here before.
I don't know how many docs are listening to this. I think it's mostly going to be a medic audience, but I don't think many docs, unless they've actually been in the pre-hospital environment, understand how chaotic it really is. And so, be nice to your medics, because when they come in and, oh, what the hell? They don't know anything. It's like, yeah, you should have been there. You would have understood. Like, you don't have a pristine cognitive environment in the field many times. And so, yeah, if they get them to me at all, I'm just happy with that. And so I have nothing but the utmost respect for the misery. I run a pretty, Nick has the exalted ivory tower up there on the, on the higher floors, but in the EM, it's already, it's kind of a chaotic, miserable environment, and it's like 10x worse in the field. So at least for me, when medics come in, I just appreciate that they managed to get there alive, and I don't give them crap. But by the same token, it's great to give education. If you would have done something differently on a patient, I try to relay that to the medics, and hopefully I do it in a way that doesn't make them feel like, they should have done that. It's just, here's my, difference of in my environment, what I would do. And if you could establish that relationship, then, you have this wonderful back and forth between the various levels of care that, makes for really strong relationships between the medics and the docs. So I don't know. I'm just free forming at this point, just my warm, fuzzy emotions. So maybe you cut that out, Mike, if that was completely useless.
No, it was great. All right. Well, guys, thank you for coming on. I can't thank you enough. Doc Weingart, it was great meeting you. Been listening
Pleasure,
to you
man.
for a long time. I was a
Crunch,
young
appreciate
and
you hosting.
bushy-tailed medic running on a treadmill, listening to you talk about endocarditis and the laryngoscope as a murder weapon. So you're definitely helping people out. And you are too, Nick.
Oh, thanks. I tried to. Hey, now you have a bushy mustache, so I'm sure it's better.
Yeah. All right, gents.
All right, guys,
well, you guys have a
appreciate
good
it.
day. Thank
Yeah.
you.
Thanks.
All right.
Have a good day.
Thanks so much.
Happy Halloween.
All right.
See ya.
Take care.